Right. Looks like we have over 60 people, and so it looks like people are still joining, but we can go ahead and start.
Okay, and I will introduce Dr. Ammar for Grand Rounds. It's my pleasure today to introduce Dr. Ammar. Some fun things I can tell you about Adam. Adam went to college at the University of Illinois, and from there, he went to Albert Einstein for medical school. I'm sorry, not for medical school. He went to University of Illinois, Chicago College of Medicine for medical school. He did his neurosurgery training at Albert Einstein. And then Adam went to Harvard Medical School, where he did a global neurosurgery research fellowship. From there, he went to Johns Hopkins, where he did his pediatric neurosurgery training. And his interests and focus lie in global health and global neurosurgery. So you've seen him around the hospital, and I'm very proud and excited to introduce Dr. Adam Ammar. Adam, you got it. And you're muted. I think you're still muted.
How about now? Perfect. Thank you, Kathy, and thank you all for having me here. It's an honor to be giving grand rounds. As Kathy said, my passion is in global health and global neurosurgery, and that has been my research focus. On the clinical side, I have a passion for hydrocephalus and congenital defects, but fresh out of fellowship at Hopkins, I'm, as most pediatric neurosurgeons, a generalist. When deciding what to do today, give this talk on, I don't know if you guys want something clinical or focus on my research, so hopefully you find some interest in my global work. Can you all see my screen?
Yes.
Thank you. So today I'd like to talk to you guys about global neurosurgery and really what lessons we can take from it and apply to the care of our patients here back at home. I have no disclosures. I will not be discussing any investigation or unlabeled use of products. So when we think of global neurosurgery and any kind of global surgery, global health, the image that usually comes to mind is mission trips. This is a very old school way of bringing care to people in other countries, where we take what we know, we bring equipment, we bring supplies, they don't have the necessary resources, and we bring that with us, and we practice our care the way that we would try and practice here. And there are situations where this can be beneficial for people, but this is a very small aspect of what is needed globally, and sometimes taking what we know here and just applying it to other resource settings isn't always beneficial, can even sometimes be harmful. And so really in the past few decades, we've started to change our perspective on what is global neurosurgery. And in my time working with the World Federation of Neurological Surgeons and the Global Neurosurgery Committee, we came up with this definition, which is the clinical and public health practice of neurosurgery with the primary purpose of delivering timely, safe, and affordable neurosurgical care to all who need it. And these three aspects are extremely important, especially the affordability aspect, which we'll get into a little bit later. But you'll see public health is really at the center of this. It's not as much about the clinical care, but there has to be this public health practice. And so looking back at public health, how did it come to be? There's multiple people that really brought public health to the forefront. Some of the best known are really around the 1800s in Europe, where previously medical knowledge was historically an empirical practice. Somebody would do care for a patient, it would work, and they say that worked before, it should work again. But then people started saying, well, at a population level, there's different aspects that you need to consider. And we should really be looking at mathematics and applying this. And this is when we start bringing in normal curves and population studies and using statistics to get a better sense of what actually is beneficial for patients and what's beneficial at a population level versus at a individual level. And so you have people like Adolphe Quetelet and Pierre-Charles Alexander Louis who did that. And then you have William Farr, who around the time with John Snow, as most people know, with the well and the cholera outbreaks at Broad Street in 1854, William Farr took what John Snow was doing and developed modern bias statistics off of that, and then started applying it beyond just that one case and made it a staple within British politics and health. Then we get into somebody who's very well known as Florence Nightingale. And so within the Crimean War, what she noticed was that more people were dying from the conditions in the hospitals than were dying of actual bullet wounds. And so it was 19,000 deaths from illness versus 4,000 from wounds, which is just unacceptable. And the thing that she brought to public health, beyond just understanding that there are factors outside the specific disease that we're dealing with that can affect our patients, is advocacy. And advocacy she really brought back home even after the Crimean War. And that was really the start of taking public health, of understanding diseases at a population level, and then advocating for changes at a large scale in order to improve the health of people. And so when we go back to neurosurgery, how have we brought this into play? And it really, once again, it wasn't until very recently that we started to bring public health into the forefront. The history of global neurosurgery is really just a focus on training. Lots of organizations existed bringing specialty training in different techniques, neurosurgical training to corners of the world that just didn't have the resources to do it. And so we would train up neurosurgeons, but a neurosurgeon without the system surrounding them is pretty useless. And so in just 2016, actually, the Bogota Declaration on Global Neurosurgery at a World Congress was developed, and that was presented to the World Health Organization in Bogota, Colombia during this conference. And essentially they were saying, we need a change. We need to have a paradigm shift in how we think about global neurosurgery. It's not just about training neurosurgeons. We need to be working with all other specialties, with global health experts, in order to make sure we're building up systems of care that work together that can actually support the care for the patients. And so with that, we started asking really these two questions. What are the issues and how can we address them? And this first question is extremely important because we have to remember that we are not the ones coming up with what are the issues. We are the ones that are asking that question. And so it needs to really be coming from our local partners, asking them what is important to you, what are your values, and what are the things that you believe need to be worked on and improved, rather than us in a colonial mindset coming and putting our own values onto people. And so we developed these global surgical indicators by the Lancet Commission around 2015, looking at the different aspects of care that are important for providing safe, affordable, and timely surgical care. And so the first one is access to timely essential surgery. And a lot of times you'll see this 2-hour window that's developed from OBGYN data on patients that are having hemorrhage after birth, and how quickly do they need to get to the hospital before it becomes too late. And so in general, you want people to be able to have access to a facility that can provide care for them within 2 hours. And many parts of the world, even within the US, that doesn't exist. The next thing is surgical anesthesia density and OBGYN density. And what you want is just to have enough physicians that are available to provide that timely and essential care. Surgical volume is really just about if you have enough people and you have the infrastructure, are you doing enough cases so that you're doing them properly? You want to be looking at perioperative mortality and outcomes. And then you'll see that we actually have 2 indicators for finance here. One is the risk of catastrophic expenditure. That's where you take somebody and you completely decimate them with the cost of medical care. And so if you have somebody with a catastrophic expenditure for healthcare, they can no longer afford to eat because of it. And then there's risk of impoverishment, where they might be able to still afford to eat, but now they've gone from somebody who can live at a normal state who is now impoverished, and it becomes extremely difficult, and they're having to make decisions regarding the rest of their life just because they needed necessary medical care. So both of these, we want it to be a 0% rate for. Next, we then looked at surgical systems. So there's 6 components of a surgical system. What we're looking at is not only do you have the infrastructure and workforce that are available for it, but when you have those 2, are they set up in a way where you can actually provide service delivery appropriately? Next, then you have to have the financing to be able to do all of this, which is extremely important. It is often the bottleneck in a lot of efforts. And then you also have to have information management. We can't do anything without data. We're making up plans without data. That means we're just guessing at what's actually needed. And so we need to be able to be collecting data as we're doing this to make proper smart goals and to provide necessary steps for improvement. And then lastly, governance. So we can build a hospital somewhere. We can provide all the rest of this to provide care. But at some point, you really need to have the government involved. And it's usually better to have them involved from the get-go because, one, they can provide financing, they can provide a lot of these other aspects. But also, if you're providing care and there's political forces that are limiting your ability, that's only going to harm you. We need to be advocating at a government level in order to provide the appropriate care for our patients. And then from there, once you have the whole system, how do you provide the actual surgical care? And you'll notice surgery is just one aspect of this, and it's only the 4th one in the list. So the first thing that we have to do is surveillance. Then this is really where for pediatric neurosurgery, pediatricians, primary care doctors, and public health experts who aren't even clinicians really come into play, because we need to understand the diseases that we're dealing with so that we can not only be monitoring patients and catch them early, but also so we know what resources we need to put where. The next then becomes prevention. Once you know about the diseases, how do we make sure that you don't need surgery? The best surgery for anybody is really no surgery. And so if we can get to you and stop the disease or treat it before you get to the point where you need surgery, that's really the best thing for you. Then you have pre-hospital care. It doesn't matter if we can catch all of this. It doesn't matter how good of a surgical service you have. If the patients can't get to the hospital and get the care necessary to get them optimized for surgery, they're going to have bad outcomes. Then you do the surgery, but after the surgery, especially within neurosurgery, rehabilitation is extremely important, because a lot of times for patients, especially with brain and spine diseases, they have injuries that we as neurosurgeons can treat and stop the ongoing harm that's happening, but their recovery is outside of our hands. And the rehab doctors and the care that they get afterwards is really what makes them better, not the surgery itself. And so we take all of these, and how do we go about this? And so I'm just going to show some of the work that I've done in my short tenure in working in global neurosurgery to show how we gather data to then utilize it to actually make a difference. And so this is a map of Afghanistan looking at access to medical centers and access to care. What we do is we map out where medical centers are. And the capital of Afghanistan is Kabul, right over here. And you'll see patients within city centers have a better access to facilities, but you see vast majorities of the country are not covered. It's extremely long. It's more than 2 hours to be able to get to center. And in some countries, the map can be small, but depending on the terrain, especially in a place like Afghanistan where it's very mountainous, it could take much longer, even if you're relatively close. So it's important to understand and develop these maps with the specific country, the specific region, even just the specific city in mind. Next, we wanted to look at the neurosurgical workforce and mapping out the global workforce. You'll see something that's not unexpected. Essentially, high-income countries, Europe, Americas, they have a good density of neurosurgeons. And then Sub-Saharan Africa and Southeast Asia are really have a deficit. Surprisingly, Latin America has actually been very good, and a lot of the countries there have made a lot of efforts to improve neurosurgical care. And so they still have a lot of issues in terms of needing more physicians, but they've made great strides just starting from 2015. And then we get access to barriers to neurosurgical training. And so when you're looking at how do we get more neurosurgeons in order to provide care, one of the biggest things is do we have the appropriate training for them? And one thing that we found when we were looking at this is a lot of these countries in Sub-Saharan Africa and Southeast Asia where there is a dearth of neurosurgeons, students have to pay in order to go through training. And this creates huge problems in terms of equity. People who have the money to begin with are usually the ones that can then afford to actually be trained to be a neurosurgeon. And you get the problem with diversity and representation. But also, most people aren't going to be able to pay to get trained. And so you're just not going to have that many people going into training. In addition to that, their training is going to be hurt because a lot of these people then have to have a second job in addition to going through residency training in order to make money, in order to pay for their training. And so this all leads to a bottleneck in terms of trying to get enough neurosurgeons. And then even if you have all of the infrastructure available, you want to look at what are the patient out-of-pocket expenses. Because if it's going to be a catastrophic expenditure for a patient to be able to get care in a country, it doesn't matter how good your care is. If a patient can't eat after getting their brain tumor removed, then you've actually ended up hurting them. No matter how good their recovery ends up being, as soon as they leave the hospital, their life is in shambles. And so that's something that's extremely important to look at. There's been very little data. It's extremely hard to collect. And this is really where working with ministries of health can be a benefit. In addition to this, just research equity is an extremely important aspect of the care. And so in order to get that information management, to collect data, you need to be able to have the infrastructure for people to actually study their own outcomes. We can't say something in the Americas has worked. We did randomized controlled trials, and we've seen the efficacy of a treatment here, and so it's going to be effective in another scenario. A lot of times, treatments that we have here just aren't able to be translated to other countries because we're looking at the difference between efficacy and effectiveness. And so building that research infrastructure in order to allow people to gather data on treatments within their own country is important. And one big thing that we all see everywhere within research is the publication within journals. A lot of times, most journals are in English. You either have to pay to publish or you have to pay to access it. And it's usually difficult for people from other countries to get publications. One, because English isn't their first language, and so it's difficult for them to write a paper that's seen as good research simply because the language is difficult to understand, or because they don't have the appropriate research capacity, and so they don't have any mentorship that goes on with it. And so one thing that I helped create just for neurosurgery was a new journal that was fully open access for everybody, that really focused on equitable representation for all regions of the world, and are now starting to focus on developing a research building capacity arm in order to get people who have a lot of research experience to mentor those who want to get into it. And so it really becomes a social endeavor, which I think is really what research has always been about, academics has always been about. And the goal at some point will be really to be multilingual in order to get free translation services so that people can write an article in one language and they can then get it published in multiple other ones, and people who want to read other articles can then get those other articles translated to their language so that they can read and understand the literature that's out there in the world. And this is something that's not specific to neurosurgery. We really need it throughout all aspects of medicine. And so when you're doing all of this, you can't do it alone. You need to coordinate with organizations, you need partners. And so these are some of the partners that exist within neurosurgery. The American Association of Neurological Surgeons has really made a big push lately. ISPN, the International Society for Pediatric Neurosurgery, has been at the forefront for a few decades now. And it's heartwarming that pediatrics has really been the leaders within the global efforts. And I think it's because we, as pediatric caregivers, understand the necessity to provide equitable care across the globe for all children. And we also have partnerships with groups like Intersurgeon, which is a website where people join in as members, and it connects those who are looking for assistance with something and those who have the resources to provide assistance, and allows you to connect and then develop partnerships from there. And then, of course, the World Federation of Neurosurgical Societies, which tries to bring together all neurosurgical societies across the globe and all neurosurgeons in order to work on these efforts. And so when we're then have all these aspects and we understand what's necessary to be done, how do we go about doing it? And so this is really where at Harvard, they've focused on the development of national surgical obstetric and anesthesia plans. And this is essentially working with a government to say, how do we take all this information and create a plan and implement a plan in order to improve surgical care within the country? And you'll see the first thing is getting ministry support. If anybody knows about the Cotter 8-step rules for system change, the first thing is building a coalition. And so you have to get all your stakeholders together. Then you do your situational analysis, you meet with the stakeholders, and you go through the information and set your priorities. And once again, these priorities have to be set by your local partners. We cannot put our values onto others. It needs to be coming from the ground up. Then you draft it, you monitor evaluation, you develop to see how much it's going to cost, figure out based on your priorities where you can provide that money. Then you develop the governance, the laws that need to be changed in order to provide support for this within the country. And then you implement it and you keep going around in the circle until you, as you continue to improve it. And it's just like as we do within the hospitals with system changes, it's a continuous cycle of assessing what we're doing, making changes to it, implementing it. And when we're doing this, these are all the things that we're looking at, really, that it's part of the things that we already discussed with the surgical indicators, but we have to ask all these different questions. It's a huge process to go through to figure out what is our priority, because it's easy for me as a neurosurgeon to say neurosurgery is the most important thing that needs to be focused on, but in reality, often it's not. And when we're looking at a health system, we can't just say, we need to improve surgery. We have to say, what's the most important thing? A lot of times it could just be primary care. It could be infectious disease issues. And we have to look at this and then say, what are the things that we can provide from a surgical perspective that can build infrastructure to help in multiple settings? And so what we saw with COVID a lot of times was that patients needed, hospitals were using operating rooms to care for patients as an ICU setting because we had the anesthesia machines, we had ventilators in there, they were set up in order to provide critical care. And so if you can build operating rooms within hospitals that can then double as ICUs, you are now providing critical care for medical patients, as well as the ability to operate. And you develop your infrastructure around what are the actual needs there, and thinking outside the box on what we are looking at and what we can provide. And this is just another assessment tool that we developed at Harvard, looking at the surgical assessment and how you determine what a hospital can look at. And we adjust these for neurosurgery for whatever specialty it is. And so just a little bit about my work in Afghanistan, which has really been the focus for me over my tenure. Just looking at the situation in Afghanistan, 2016, 2017, about half the population was under 15. Half of it was living in poverty, and the majority of it actually lived in rural areas, even though the hospital centers were situated in the cities, in urban centers. And so you're with this very unique situation where it's difficult to provide care for these patients. And but in 2018, they had about 30,000 health facilities that were functional. 80% of the population was within a 2-hour distance. However, this was mostly for primary care. The majority of higher tier facilities were still concentrated in urban areas. And you have this issue when you're looking at a mostly rural living population. And looking at the health expenditures, it was about $60 per capita, 10% of GDP, which is extremely high. And when you're looking at that, the vast majority of it was out-of-pocket expenses. Only 5% was coming from the government. 16% was from charitable organizations. And so you have a situation where it's very tenuous in providing care for patients. And what happened in 2021 when the government collapsed and the Taliban took over and the U.S. pulled out and put sanctions on the country is that the entire system collapsed. The United Nations had to step in and pay salaries for people just to keep the health system running. And it's still, even 3 years later, the health system is still in dire straits. And it's difficult to get equipment and supplies in to provide care for the patients. And so we looked specifically at neurosurgical hospitals. We found that they're located just in eight cities. 10 of them are public, 5 of them are private, and 1 is military. And so patients don't even have necessarily access to all the neurosurgical hospitals that are around. The neurosurgical workforce, so a recent estimate from 2016 showed that there were 124 neurosurgeons in the country. But that was based on model data. Our data from surveys showed there were only 74, and the rest were actually trainees in the country, which is a little hopeful given that you have so many people that are being trained to be neurosurgeons. But the issue becomes, when can they actually become attendings? It's not a set. They do have a set training period, but because of all the turmoil that's going on, a lot of these trainees are in training in perpetuity. And they're not getting enough cases as of yet to be able to be off on their own. But you also see that there's quite a lot of neurosurgeons in the country. And the issue here is not now that we need more neurosurgeons, it's really that we need the infrastructure for them to be able to do their jobs. Mean number of neurosurgical cases performed per hospital per year was actually 755. And only 2 hospitals were utilizing task shifting, where general surgeons would perform neurosurgical procedures. And so you'll see that there's a lot of room for improvement here. We have a lot of neurosurgeons. We're not fully utilizing task shifting. There's ways to improve neurosurgical care for patients. But once again, back to those sanctions, getting equipment in for them to be able to do their job becomes one of the biggest things that we've had to deal with in our work in Afghanistan. This is just a map of the different neurosurgical hospitals. As you'll see, most of them are situated in Kabul, the capital of Afghanistan, and you have the vast majority of the country that's living far away from any of these centers. And so when we were looking at what we needed to do, we followed the ENSO model, where the first thing we needed to do was build and gather a coalition. It took about a year working with different neurosurgeons, trying to get the Ministry of Health involved, and developing a core team that could really work to improve the care there. And it took so long because that is the important foundation. Without that, we couldn't do anything. And one of the issues with the Ministry of Health is that with the government turnover, it would keep switching who was the point person to talk to. And so it became very difficult to work with the government, but we needed to continue to try and maintain that relationship, because trying to do anything without the government becomes very difficult. The other thing was then the data gathering, and that's all the data that I just showed you. And even there, it was extremely difficult to get that data, and that's very poor data. We need much better data to really make a solid plan going forward. And because we don't have access to be able to go into the country, it becomes difficult for us to help our colleagues in Afghanistan to gather that data. And so we're relying on them to be caring for patients in a tough situation while also trying to gather data. And so it's very slow going, but it's trying to find different ways, especially virtually, of how we can assist. And so that's when we focus on fundraising. And whenever we're working in other countries, we learn the importance of the international diaspora. There's an Afghan American community within America, and they have an entire organization. We went to them, and they want to help out their fellow countrymen back home, and so they helped fundraise a lot of it, and as well as looking for grants and other sources of money. And then, as I said, working virtually has become more and more important ever since COVID. And so one of the first things we did was obtain internet capabilities for our colleagues back in Afghanistan. Working with a telecom company in Afghanistan, we got them Wi-Fi capacity. And so before it was difficult to even have meetings with them. Now we're able to have meetings on a weekly basis because they actually have access to internet. And then the last thing that we've been trying to do since then, after gathering data and seeing that really equipment needs are the most important thing that they need right now, is trying to bring in equipment. And there have been multiple attempts to find a sustainable transportation route. Because of the sanctions, because of a lot of countries cutting ties with Afghanistan, there aren't the same number of transportation routes that had existed before the collapse of the government. And a lot of these also have huge customs costs and taxes. And so you don't want most of the money that you're raising to bring in equipment going to taxes. You want it going to the equipment to the patients themselves. And so this has been an extremely difficult aspect of it. And it's one of these things that we've learned that is extremely important to figure out what's the best way. And it's just one of those pitfalls that we've encountered along the way. And so this then brings me to what about pediatric neurosurgery? I've talked a lot about general neurosurgery in other countries, but how does this come back to us? And so in general, for pediatric neurosurgery, there's been a good amount of data, but not as much as for the adult side. One study that was performed was looking at bellwether procedures, which are essentially indicators of can your system care for these patients, as well as what are the necessary procedures that are the most important to be caring for patients. And so for pediatric neurosurgery, through a Delphi system, determined that there are 6. The shunt for hydrocephalus is important to be able to do, myelomeningocele closure, performing a burr hole trauma for a craniotomy, infection treatment with a cerebral abscess, and external ventricular drain insertion. And you can argue about which ones are actually necessary. But essentially, if you have the equipment and the infrastructure to be able to perform these surgeries, you can then perform more complex ones because you have the foundation. We then also looked at access to pediatric neurosurgery. So there's estimated 2,300 pediatric neurosurgeons in the globe. 85% of them are within high-income countries. That means that there's roughly 330 pediatric neurosurgeons caring for 1.2 billion children in LMICs. And it comes down to a density of 1 pediatric neurosurgeon per 30 million children in low-income countries. And some of this has to do with how you define a pediatric neurosurgeon, especially in sub-Saharan Africa. General neurosurgeons treat pediatric neurosurgeons. They're just not going through a subspecialty training, but a subspecialty training pediatric neurosurgery is a very Western idea. And so in a lot of these countries, the idea of training for pediatric neurosurgery isn't something that they're looking at. They look more at technical training. And so we do a lot of endoscopic work within pediatric neurosurgery. And so their focus is, I want to be able to learn how to do endoscopic work to provide these specific treatments for my pediatric patients. Less so, I want to be called a pediatric neurosurgeon and go through an official fellowship. Then we're looking at different diseases. So pediatric hydrocephalus, the incidence of congenital hydrocephalus is much higher in low and middle income countries. It's the highest in Africa and Latin America. Unsurprisingly, it's the lowest in the United States and Canada. And the etiology is different in different countries. In America, the etiology for congenital hydrocephalus is often hemorrhage. Within low income countries, it's often infection. And this affects the treatments that exist as well. For pediatric trauma and spine injury, we have a global incidence in kids less than 20 years of age, estimated about 14 per 100,000 children, mostly due to road traffic accidents. LMICs, of course, have the highest pediatric spine injury case burden. And a lot of this has to do, once again, with not anything to do with pediatric neurosurgeons, but this goes back to governance rules. Within Vietnam, a lot of the trauma was because of people riding around on scooters without helmets. And so when they initiated helmets laws for patients, we saw a huge plummet in cranial traumas, and seatbelts. Having seatbelts has reduced the injuries of traumatic spine injury in high-income countries, and developing governance for that in low and middle-income countries can have a much bigger impact here than any kind of neurosurgical capacity building. And then lastly, spina bifida. This is one that really showcases the need for us to focus less on neurosurgeons and more on the diseases for our patients and what's the best way to treat this. So the incidence of spina bifida is 1.67 per 1,000 live births for total neural tube defects, which includes anencephaly and everything, 1.13 per 1,000 for spina bifida specifically. And so that's approximately 190,000 newborns each year in LMICs. And most of this is from deficiencies in vitamin and mineral status. That's not to say that you give people folate and it's going to fix it, but this is a huge opportunity that exists, especially in low and middle income countries, for us to do prevention. And so the Global Alliance for Prevention of Spina Bifida, which was started by a pediatric neurosurgeon down in Alabama, worked with neurosurgeons across the world, with public health experts, with pediatricians, with OBGYNs, and developed the WHA, the World Health Assembly, Article 76.19, which is a resolution that urges member states to make decisions on food fortification. And that's just really the first step, is just urging people, but implementing is much harder. But it shows that it's a focus really on not on neurosurgical capacity, but us as neurosurgeons, we need to advocate for what's best for our patients. A lot of times prevention is the most important thing. And so how does this apply to us here? This is a lot of global work. You might not be interested in global work. You might not be interested in the surgical aspects of it. But there's lessons to really be learned from this. And the first one is systems level action requires coordination with all associated pediatric specialties. And so when we're doing this, we can't work in isolation. We have to be coordinating with everybody, just like with the WHA 76.19 resolution, where it's more about what's best for the patient, not about what's necessarily best for our specialty. Prevention and surveillance are the first and most important components of pediatric neurosurgical care. And us as neurosurgeons, we could try and do that, but really primary care doctors are the best situated for that. And so you are the front line. You are the most important aspect for neurosurgical care, not the neurosurgeon. And then lastly, the important thing that I wanted to point out is local is global. We have parts of the United States of America that have healthcare systems that are worse than in low and middle income countries around the world. We have issues in public health here back home, and so we don't have to go to other countries in order to implement this idea of global health. It doesn't have to be in another country. It can be right back here in our own backyard. And so, there's been a big focus lately on precision medicine, looking at genetics and targeting our care to our patients based off of their own genetic morphology. But really, we forget a lot of times that some of the most important aspects for our patients is their sociodemographics. When we're talking about precision medicine, we have to remember that a lot of the precision individual risk factors for them come from their socioeconomic situation. And this stems from things like social economic policies, things that are developed from, things like Roe v. Wade that have lasting impacts, political and governance issues that will affect our patients at an individual level. And so the importance of advocacy and being involved in politics for us and making sure that the laws that exist are good for our patients is something that we as physicians should be involved in. At an institutional level, making sure that the policies we have within our hospitals, within our institutions, are what's best for our patients. And then within the neighborhoods and communities, it's not just as soon as they leave the hospital, they no longer need medical care. What are the situations that exist in our patients' communities that can be hurting them? Their living conditions and their social relationships affect them than their individual risk factors. And all of these have just as big of an impact, if not more, than a lot of the aspects that are at a genetic system within our own bodies. And when we do this, we're looking at, better, more personalized care for our patients. But then when we start looking at what are all these factors that affect our patients, we're also improving population level health data overall. And when we improve the population health data overall, it improves our patients' care. And so this is not a vicious cycle, but a merciful cycle that things will continue to improve and improve if we focus not just on our patient alone, but the population as a whole, and it will keep benefiting both as we go through. So with that, I'd like to open up to any questions. Thank you all for having me here. maybe in the future, if you guys enjoy this talk, I can give something on a topic a little more clinical. If you'd like, happy to talk about anything.
Thanks, Adam. I think there are some questions in the chat, but I don't know if anyone else has any questions. While you're looking at that, I was wondering, when I was in Kenya with Dr. Albright, he was very involved in training neurosurgeons in Kenya for pediatric neurosurgery. But one of the things that we saw, especially in Kenya, was that many of the neurosurgeons we trained, after they were trained, they left Kenya. How do you prevent that kind of leakage?
That's where really governance and working with ministries of health is extremely important. When you're training physicians, you see a lot of brain drain that goes on in countries, and you can't blame people for doing that. They need to take care of their own families, and they need to take care of themselves. And if they get trained, but there's no infrastructure for them. In a lot of countries in sub-Saharan Africa, I know a lot of surgeons who went and got vascular training, being able to do endovascular work in other countries, and they come back home and they don't have the infrastructure to do the care that they were trained to do. If they don't get paid enough in order to do it. A lot of countries, you'll see a lot of neurosurgeons work in a public hospital trying to care for patients, just like we do here at a place like University Hospital, or in New York, Bellevue, and the city hospitals. Those same physicians that have a private practice elsewhere, and they have better equipment within the private practice, they make their money off of that, but now you're splitting your care between those who can't afford it and those who can. And when it comes down to it, you're going to be incentivized to care more for the patients who are paying your bills and can keep your family fed than the ones who can't afford it. It's not their fault that they can't afford it. And so you really need a government that's going to support this and take that out-of-pocket expense away from the patients, and figure out a way to make sure that everybody can get equitable care.
I don't know if you're able to see some of the questions in the chat. The other thing I was going to ask you is how close do many of these international organizations work with and utilize social workers? Because I find the social workers, there's such a need for social work and social support for these families, especially on discharge. But many of the low, the hospitals where we work, even in New Jersey, in low-income neighborhoods, there's a shortage of social workers, and the families are not getting the support they need after discharge.
Yeah, and I mean, having social workers is something that we're very privileged to have here, even though there's a huge shortage of them. Not only is there a shortage of social workers in general, they get paid very little. And so there's no incentive for people to really go into it. And the ones that we do have are overworked. And this gets into Dr. Clemente's question about Medicaid. Is we do have a lot of issues with Medicaid patients, and it's tied a little bit to the social workers as well, because these patients will come in, they could see us. With our practice, we take almost all Medicaid patients. And so I don't have as much of an issue in terms of, I can't see this patient, I can't operate on them because they have Medicaid. The issue really then comes in when I'm trying to get care at a hospital and the OR time is delayed because the hospitals that will take that Medicaid are limited. And so some of the delay can happen there. And then in addition to that, some of the hospitals like University Hospital, we don't have pediatric subspecialists. I don't have pediatric endocrinologists there. I don't have a pediatric oncologist there. And so it doesn't matter what insurance you have. If you have a brain tumor or you have an endocrinologic issue, just because you have bad insurance doesn't mean that the disease is going to just go away on its own or it's not going to affect you. And so we need to make sure we have that care for these patients. And a lot of times it becomes difficult, and that's where a lot of the advocacy that from public health needs to be applied to medicine. And we need to be working with our institutions and with the government to make sure that these patients have access to the appropriate care. And with the social workers, making sure that we have more social workers, even within a private practice. It could be extremely beneficial to our patients and probably even financially beneficial for a private practice to have its own social worker to help these patients through the coordination, because then you can drastically reduce complications. You can make sure that patients will get to appointments on time, get to surgery. I've had patients who, we could get a time slot for them to get to surgery. They couldn't get transportation to get to the surgery. And we had to move mountains to get that set up. And the way we moved mountains was with the help of social workers. And if we didn't have them, I don't think we would have been able to operate on the kid because they wouldn't be able to make it in time for the surgery. And finding another time slot would just delayed their care over and over again. Yeah, in Puerto Rico. So Puerto Rico is an interesting situation within the U.S. Could talk about for hours, where it needs to be a state and have proper representation, and it's something that we as a country are putting a colonial aspect on them, and we don't want to admit it. But I think the hijacking by insurance companies and hospital corporations, I don't know if I'm allowed to say anything bad about Atlantic Health. It's been a good system, but in general, any health system, any insurance company, their goal is to make money, not to care for patients. And so a lot of times we get pushback from insurance companies and from hospitals about, we think that this is the best thing for our patients. And they disagree because it's not financially viable for them. But that's also why it's so important for us to keep them in the loop. When we're trying to do these, they need to be one of the stakeholders in these discussions, because sometimes it is right. It is true financially. If we can't support it, if we can't afford these programs that we're trying to build for our patients, then it's going to collapse. The money has to come from somewhere. And so the people with the money, the corporations, the insurance companies, we should be working with them as stakeholders and advocating and seeing what their perspective is and trying to tie it into a system where we can come up with a financially sustainable solution to improve the care for our patients. And so rather than simply vilifying them and refuse to work with them and combating with them, a lot of times it can be beneficial to try and partner with them. The same way that, some insurance companies have started pushing patients to get guideline specific care and giving reimbursements to patients. There's a lot of issues with that, but trying to improve the care for the patients while also saving money can a lot of times be attainable.
Thank you. There was one more question in chat. Hang on, I'll read it to you. What are some ways to get community leaders and especially the government on board to accept the work that you're doing in their communities?
Yeah, so I think the biggest thing is having an open mind and bringing them in at ground zero. If you come up with a plan, iron it out, and then take it to community leaders, they see you as trying to force your ideals on them. But if you bring them in at ground zero and start talking to them, once again, it's not about what you believe is the best care for the patients and the people in the community. It's about what do they think it is. And if you have an opinion, you discuss it with them and you provide the data that you believe showcases why you think which needs to be done is important. But you also have to be listening to them and what their needs are, because we have only one perspective. And a lot of times, the perspective of the community leaders, of the people in the community, it's less on their medical care. For a patient who is deciding between getting care for picking up their prescription and getting food on the table, a lot of times they're going to choose food. And you can't blame them for not picking up their medicine then and saying that they're non-compliant. You need to be then going to them and talking to them and seeing what are the issues. Why can't you afford that? What are the other things that we can focus on outside of medicine that can help you then get better medical care? I think that's really where it comes in when we work with community leaders and the government. We have to, our focus is on medicine, but we have to pull ourselves a little bit away from that when we get to those levels, because we have to be looking at downstream effects. And sometimes advocacy, such as within folate fortification of foods, that's not a medical treatment. That has nothing to do with medical systems. That's working with agriculture and industries that are outside of medicine that will have downstream effects in order to improve the care for our patients. And so taking that step back and really seeing it from their perspective a lot of times can be beneficial.
Mm-hmm. I think another way that physicians should be advocates, especially in regard to telemedicine, with the advent of COVID, most physicians now have the ability to do telehealth. And especially in neurosurgery, this was great for patients in areas like Newark and other areas where you have families where both parents are working, they have several children at home, they don't have a car, they can't get to the office. They would rely on Medicaid transportation, which some families can't coordinate. So the ability to do telehealth going forward is so important for these families. I think, every chance we have as physicians, we have to let Congress know that they have to forever extend benefits for telehealth so that these families have access to care. I mean, obviously, it's not ideal. If you're evaluating child, you'd love to be able to see that child face to face. But in reality, if the family can't get the child to your office, the next best option is telehealth.
Absolutely. And one way that also helps us in advocating for that is, connections. We care for patients. One of them is within politics or an industry leader anywhere in whatever field it is. That's a connection that we then have, and sometimes we need to rely on that and the people we know. And a lot of times it's just about those relationships. And the work that we do in Afghanistan, our connections to the Ministry of Health are through the neurosurgeons there who are just friends with some of these people who are within the government. And that's what gets us our in, and that's what allows us to start that relationship in order to start building it. And so it just comes down to it's really just, we're people in the end. And if we could step away from our agendas and just understand that the people we're working with are people just like us, we're just having relationships with them. A lot of times everybody's goals in the end really are the same, to improve the health for all of our patients.
Mm-hmm. Very good. Well, thank you very much for your presentations. I don't see any more questions in the chat. I've been checking it. So I think we are good. Thank you so much for your presentation. And if you ever have a question for Adam or want to get more involved, feel free to email him. Okay.
Yes. Thank you all. I also put my cell phone up there. I guess I can share it again really quickly, but if anybody ever wants that as well, call me directly, email me any questions like that. And if anybody is doing global health work, wants to collaborate, I'd love to talk more. Thank you so much.
Thank you. Have a nice day now. Bye.
Bye.